Good morning or good afternoon for everybody who's joining us today. Thank you for joining this webinar. This is our August 2018 live webinar with Brownwood Biomedical. I am going to be your moderator today. My name is Luis Jimenez. I am the Vice President of Business Development for Brownwood Biomedical. And I am honored to share this webinar opportunity with our Principal Consultant, Sarah Griffith. Just a few housekeeping items before we start. This webinar is live and you can submit questions at any time by pressing the Q&A button that is in the bottom. We will be addressing the questions at the end of the webinar, but as mentioned, you can submit them at any time. Just a little bit of background on Brownwood Biomedical. We are an international regulatory consulting firm specialized in medical devices, diagnostics, and pharmaceuticals. We have offices in Beijing, Hong Kong, Taipei, New Zealand, and more recently, a presence in the US. We do end-to-end regulatory consulting from initial product strategies all the way through approvals, post-market services, and of course, reimbursement. It is an honor to have you here today. We look forward to a very productive next session. As an introduction to Sarah Griffith, she has over 25 years in medical technology. Her background includes healthcare economics, insurance, policy and legislation, medical finance, reimbursement system, and even government relations as a registered lobbyist. Sarah has international positions previously before joining Brownwood Biomedical with the likes of St. Jude Hospital and Mercy Hospitals in the US. And she is part of the reimbursement subcommittee of MedTech Australia and the healthcare economics expert panel with Oz Biotech. With that, I'll hand it over to Sarah, who will be talking to us today about the MSAC process and what applicants need to know. Thank you very much.
Thanks, Luis. Let's get started. So we're going to talk about the MSAC process. For those of you, I guess that most of you who have logged on have a little inkling of what it is, but we'll delve into it a bit more deeply, and hopefully you'll have a better understanding by the end of the webinar. I'm going to go through some background information first, just on Australia, so we can set the scene. Australia is very big. So we have 25 million people in an area roughly the size of mainland Europe, actually greater than mainland Europe. So we're really quite sparsely populated, but we have really in quite large cities, particularly on the East Coast. It's a really very sophisticated and mature market, so it's a great place to do business. It's generally quite profitable and rewarding for medical device manufacturers, and like every other sophisticated economy, we have an increasing reliance on high quality clinical and economic evidence. And like all other economies everywhere in the world, we are subject to budgetary pressures in our healthcare. There's lots of change. So just a quick review. We have a universal healthcare system called Medicare, and that, unlike the US system, applies to everyone, not only 65, over 65. So basically, if you're an Australian citizen or resident, you are eligible to participate in our Medicare program. In addition to that, nearly half of all Australians have private health insurance. Private health insurance in Australia is really limited to hospital admissions. It doesn't include primary care and pharmaceuticals. It is quite often coverage will include ancillary covers such as dentistry and physiotherapy and things like that, but primarily it's for hospital cover. So consequently, we have a mix of public and private hospital systems in Australia. It's somewhat fragmented, and there are quite a few perverse economic incentives, but that's really for another webinar. So the medical benefits schedule is really the basis of our payment system in Australia. And what it is, it's a list of thousands of procedures and medical attendances that are subsidised by Medicare. And it also actually forms the basis for our DRG system. So it's quite important. So it covers services in outpatient centres, so doctors' visits, public hospitals, private hospitals, and therefore it's very, very important for medical technology manufacturers to actually have an MBS item number that covers the procedure that your device is used in. So, hence, we get to the Medical Services Advisory Committee. So this is MSAC. MSAC is appointed by the Minister of Health, but they are independent and operate apolitically. But their job is to advise the Australian Health Minister, and this is all these elements are very important, on evidence relating to the safety, the effectiveness, and the cost effectiveness of new medical technologies and procedures. So essentially, the Australian government, before it subsidises something, obviously wants to make sure it's safe. They want to make sure it works, and they want to make sure that it is good value for money. So, now, it sounds easy, but before you start, you really, really need to be confident in your clinical evidence. You need to have, it's no point embarking on an application to MSAC without really good, solid clinical evidence that your device or the procedure that your device is used in works well. You have really good evidence that it does that. It works better than what would be used instead, or else it's better value than what would be used instead. So if you don't have good clinical evidence, you should really wait till you do. Because MSAC, the committee, really, really prefers to have randomised controlled clinical trials. It's not absolutely necessary in all cases, because sometimes this can be hard to do in some device trials, but overall, if you don't have a good RCT or something equivalent, you should probably wait until you do, because you might waste some time and resources. Equally important, if you are bringing a new technology into Australia and you want to have do an application to MSAC, it's absolutely essential that you have the support of the professional clinical body in Australia. So otherwise, the application will not go ahead. So that generally means the college of whichever medical specialty is going to be the user of the device, whichever doctor's group or medical professional group is going to use the device. So that's really, really important. So unless you have these things, before you start, I would go back and make sure that you do. So let's go through some acronyms. So these are some terms used by MSAC. First of all, PICO. This is a term that we use a lot during an MSAC application, and those of you who are familiar with literature searches will be familiar with it. So PICO, it really is talking about the population your device is used in, what the intervention is, what would be used instead of the device, and what is the outcome. Some of the committees, the PASC is the PICO Advisory Subcommittee, and we'll hear more about it in a minute. The ESC is the Evaluation Subcommittee, and Health Technology, HTA is Health Technology Assessment, which is the process that MSAC uses to evaluate your applications. So let's just do a quick overview of the process. So the first thing we'll go through, you'll see the slide reappearing throughout the webinar, but first of all, the first thing you need to do is apply, essentially. So there's something called an initial application, and that is for the triage assessment. So basically that's determining eligibility. So we'll go from, we have the application assessment, Remember our PICO, Population Intervention Comparator Outcome. So this is where the stage where those questions are defined. And we'll go through that a bit further. PASC is the Policy Advisory, PICO Advisory Subcommittee, who will determine what goes, oops, sorry, we've just gone back a slide. Let's go. Here we go. Sorry, everyone. So then we move on to the main submission. They call it an assessment. So basically that's an assessment of the evidence, which goes to the evaluation subcommittee, which will review and critique, and finally it goes to MSAC for a final decision. So let's break all this down because it's obviously quite a complex process. So the first thing you need to do is fill out the initial application form. So it's a deceptively easy document if you look at it, and it seems quite straightforward. It's actually quite difficult to do, and you should treat it very seriously when you're filling it out, because unless you get approval at this first stage, you won't be able to progress the application. So this application basically determines whether you're eligible to be assessed by MSAC, whether the whole proposal is eligible to go through and be approved. And it's quite long. It's 53 quite tricky questions. They deal with the place the technology might hold in the Australian healthcare system, who performs it, you know, what resources might be used. You also have to not analyse your evidence, but you have to demonstrate that you have evidence to be assessed. So you have to be able to list all the available trials that you think you'll rely on in your main assessment, and any trials that may be reporting in the near future. So it's quite a substantial document. And, you know, I would say an experienced person who is used to doing them would spend 50 or 60 hours completing this document. So it's not something that you would rush through or think that it's easy. And that's a common error because it's deceptive. The questions look deceptively easy, but I can't stress enough that you really need to take it seriously. So, common mistakes at this, you know, crucial first stage. So, the first one is not having the support of the clinical craft group. So, if you've got an anaesthesiology product, you really need to have the support of the College of Anaesthesiologists in Australia. And they have to provide a letter saying that they support the application. So unless you're really confident of your support in this area, you should really wait till you have, you know, developed those relationships and got that support. Another thing is, it's not quite as crucial as the first thing, but not having consumer support, not defining the not having the support of the people who receive the technology. And this is a bit trickier because sometimes it's hard to identify the right consumer group, and quite often they are charities and don't operate in this sort of regulatory reimbursement world. But nevertheless, it's important that you try and have their support if you possibly can. The third common mistake is not defining the population well. So MSAC is very, very precise in how they look at the population that the device or the tech or the procedure is being used in, because they are always looking for where they can get the best bang for their buck. So they want to know the exact group of patients that this device is going to perform the very best in. And they will want to focus on that population. So before you decide, you know, how you're going to proceed, make sure you really define that very, very carefully and you have evidence to support it. The next mistake that people make and this is sort of, a mistake for new players, and I often find this when companies who haven't been involved in this area do this form themselves. They're not objective, they're emotive. And that's just a big turn off for the assessors, because you really, really need to be very cold, calculating, objective, and not use any sort of emotive language at all in this first application. So it's very hard because a lot of, people involved in this area are, passionate about their technologies, but it is not a good thing to be emotive. And so you have to remove any sort of bias from your application at all. And lastly, you need to have really good clinical experts. You need to nominate 2 of them in the application who are willing to participate in the process. And generally, it's good to have good communicators. Some doctors are great, but they're not good at communicating. And the other thing, they need to be available, because sometimes you need to be able to ask questions or get an opinion or answer a question on behalf of the MSAC. And if you have doctors that you can't get hold of, that can make the whole process a lot more challenging. So good communicators and who are available. So moving on. So we've been at the triage. That was the initial application. Now we're going to go to the PICO Development and PASC Consideration. Now, this is a really weird term, but what happens is, what a PICO confirmation is, it's a document that outlines the clinical and economic questions that need to be addressed in your main submission. So how this is developed, your initial application is sent to an independent health technology assessment group, usually they're usually part of some of the major universities in Australia, and they will take your application and develop the PICO confirmation. And just refreshing what that is, it's an outline of the clinical and economic questions. We will define the population. So the HTA group might define the population a little bit differently from how you did in the initial application. That quite often happens. The intervention, and which is usually pretty straightforward, the comparator. So quite often what you've nominated as the comparator, the service or the procedure that would likely be replaced by the new intervention, quite often they'll add a comparator or 2 and say, well, we really think it's, the comparator might be usual care or this drug or this operation. And that's usually, a bit of a nuisance, because it just makes your application more complex, but nevertheless, it's something that happens quite often. And the outcome. So the outcome is usually defined by the response of the patient to the intervention, but they will look at what measures they want to look at. So it might be, years of life, or, number of cancers detected, or any number of outcomes. And you have an opportunity to discuss this with the HTA group before this document is finalised, because this document is really important. That's the basis for the next stage. So going back, we see this next stage. We've got your PICO assessment. So we've got your PICO document confirmation, and this goes to for PASC consideration. So if you remember, PASC stands for the PICO Advisory Subcommittee. And so when you get to this stage, you get to go to this quite bizarre meeting. Now, I put up a picture of a congressional hearing, or this is a Senate hearing, because it's sort of set up a bit like this, but more like this whole meeting is on Valium. So there's there's a bunch of people sitting around the table, the committee, there's, a lot of public servants, and it's, a somewhat intimidating experience. So it's quite weird, but nevertheless, it's a step that you need to go through. You need to take your clinical experts with you, and generally the committee will discuss the initial application and the PICO and ask a lot of questions. And sometimes the questions can really be quite strange, because my experience is that the committee is comprised of many, many learned people and experts, and it can get a bit competitive. And it seems to me that each member on the committee is trying to ask, trying to demonstrate that they've thought of something that no one else has thought about. So anyway, once you get through, it's not an unpleasant experience, it's just a bit strange. So once you get through this meeting, the PICO confirmation will be ratified, and you have a final document from which you can work from and go to the next stage. So the next stage is the main submission. There's two ways of doing this. You can do the assessment yourself, and so this is prepared by the applicant at the applicant's cost. The pros of this is that you're in control and you have the ability to tell a story and really mould the whole assessment the way you want it to go. The cons are it's very expensive, and most companies simply, actually I would say nearly all companies, unless you're a major pharmaceutical company, do not have the resources within their staff to do one of these applications, because you require so many specialised skills. So nearly always it will go to consultants, and the cost is significant. In Australian dollars, it's 150 to 250, and depending on the number of comparators, it can be more than that. Alternatively, the department will contract an independent HTA group to do it. So this is great if you don't have the resources, because it's free. The difficulty is that you do lose control of the submission, and you are quite dependent on the HTA's group's understanding of your technology. And even though there is opportunity for dialogue, it's not a lot. So, a lot of people don't have any choice, and they have to go through this path. And it's fortunate that it's available. So this is the main submission. I've just broken it down. And we'll go through each of these sections one by one. So an executive summary, basically that's just a summary of the rest of the application. So we won't talk about it right now, but we'll go through the sections in detail. So section A, we're looking at context. So really what we're doing, we're framing how the technology fits into the Australian healthcare system. And we need to provide clinical algorithms, and that's just the complicated work for saying you need to provide a clinical pathway in a flow diagram, and, for both the new and the old service. And you need to, describe the new service in a lot of detail. How is it delivered? How does it fit into the system? Who provides it? What training? What does it replace? So you really need to get into this sort of, into this section in a bit of detail. So really, it's not a hard section, you just need to write it well. So, section B, we're really getting into the meat of the application. So, this is a clinical evaluation of the performance of the new technology. So, you need to provide a full literature search, and you need to document how that search was done, and you need to demonstrate how you selected the studies that you are relying on. And you can't just do it in PubMed. You need to do, make sure you use all the major databases like Embase and I've forgotten what that is. I'll leave that for a minute. But anyway, all the major databases, and then you need to do a detailed analysis of these trials. So you need to use some sort of standard assessment tool to look at bias, and then you need to interpret the outcomes of these trials. So this is, it's very technical, but basically what you need to do is just hone down in using, standard scientific method to demonstrate what the outcomes of your device or technology compared to the comparator, and what is the best evidence available you have to support that. So that's a fairly lengthy section, but it must be done very well. Okay, so we're sort of moving on to a bit of technical language here, health economics language. So we're looking, section C is translational issues, but simply what that means is that we're taking all the bits out of the clinical trials, all the elements that are important to demonstrate that your technology works, to populate the economic model. There's a whole bunch of things that we can use. There can be survival rates, event rates, adverse events, hospital of life, length of stay in ITU, use of pharmaceuticals, quality of life measures. So all of these things you'll extract from your trials, and you'll show that these are the things you're going to use to populate your model. Also, from the trials, you identify transition probabilities. And for those of you who are familiar with Markov models, you'll know what these are. But basically, it's how likely is a patient to have a certain event, e.g. a recurrence of a cancer, a complication, or a readmission into hospital, because all of these items have a cost and they need to be included in the model. So obviously this is quite technical. Okay, so we'll move on to section D. So section D is the main, really the key part of the assessment, because it's the economic model. So an economic model that evaluates and compares the costs and the consequences, the outcomes of both your new technology and what you're comparing it against. And usually we use either a cost effectiveness model or a cost minimisation model. So for those of you who aren't health economists, really basically a cost effectiveness model will determine if your new intervention is good value, how much the cost of the additional benefit is going to cost. And a cost minimisation is where we assume the outcomes of two interventions are essentially the same, and we only look at the cost. I would say nearly always we're going to be doing a cost effectiveness model, and a cost minimisation is usually the exception rather than the rule. So these models are usually presented either using Excel or triage software. And we don't only just provide, the raw results of this analysis, but we need to provide a really comprehensive sensitivity analysis. So this means that basically we're looking at all possible outcomes from the results of the clinical trials, and the best and worst case scenario and everything else in between. So it needs the skills of a very experienced economic modeller. These are not skills that are common, and having a good modeller is essential. Okay, so that's section D, the economic evaluation. So this section really is telling us whether the new intervention is good value or not. But something can actually be, really good value that still costs a lot of money. So, for example, if something, say if you've got a new type of implantable heart device that's very expensive, it may give you really good outcomes and it may be considered very cost effective, but still it's going to cost a lot of money to the Australian government and insurers to pay for that additional outcome, because it's a large population. So we really, really need to look at the impact of the new service, what the budget impact is, not only on the medical benefit schedule, but our other parts of our Medicare system as well. So generally that could be, public hospital admissions. It could be, very commonly, it's our pharmaceutical benefit scheme, because we have a very comprehensive subsidised drug scheme in Australia, so the impact on that. So we really want to look at overall how much is this additional service going to cost the Australian government. If you're really lucky, your new service might actually save money. So that's, you know, a bonus. So then you'd alternatively, you look at how much your new service is going to save the system. But either way, we have to look at the impact on the health budget. That has implications for, you know, the minister's decision when we finally get to that. So going back to our overall process, so we've developed our assessment report, and now it goes to the economic subcommittee, the evaluation subcommittee for their consideration. So the ESC, the evaluation subcommittee, will very, very thoroughly critique the assessment report. And this is always quite demoralising for applicants, because health economics being the discipline that it is, there's always an alternative way that you could have done something in the assessment report. So it can be quite a brutal time for the applicant, but this is normal. The ESC's job is to pick holes in your assessment report. So this is very normal. And you do get an opportunity to respond to the critique. So, and it's also an opportunity if you're had a contract assessment, that to address any misunderstandings that may have arisen during the contracted groups preparing for the assessment report. So, you know, it's important that you take the opportunity to critique the critique. You usually don't have long to do it. You usually only get a couple of weeks. So it's a pretty time-critical part of the application. And after that, ESC will make its final recommendations to the full MSAC committee, and then they will make a decision as to whether they're going to recommend a new service to the minister. So it's actually like all health decisions. This is ultimately the political decision. So MSAC only has the power to make recommendations to the Australian Minister of Health. They do not have the power to say something will absolutely be included on the medical benefit schedule. It's ultimately a political decision. It's not often that the minister will go against the advice of the MSAC, but it certainly happens. And it happens not by the minister saying no, but quite often she or he will just delay the decision. And there was a famous case where one health minister delayed a decision by 7 years, and that was for the when PET scanners were new. And so what happened then was, you know, the budget impact was so huge that he just delayed the decision rather than actually made his decision. So it was a bit notorious. But it's nearly always nothing to do with the technology, but it's always based on budget considerations. And at this point in the process, it's quite common for a lot of lobbying to go on, you know, either by consumer groups or the manufacturer or doctors, you know, to try and get a positive decision. It's probably the trickiest part of the whole process. So, how long does all this take? It takes a while. So, the initial application takes till the time you get your PICO confirmation is 6 months. Preparing the main submission generally will take a consulting firm 3 to 4 months because it's extremely labour intensive. Once you've got that submitted, if you're doing a submission-based assessment where you're paying for it, the time from submitting to the MSAC meeting is about 6 months. And the contracted assessment from the time you have your PICO confirmation till the time you get to the MSAC meeting is roughly about 11 months. The minister's decision, which is that key phase, really doesn't have any mandated time limits on it. So it's a bit open-ended. It tends not to go on for too long if it's non-controversial. But, you know, as I said before, it can drag on. But overall, it takes about 2 years. So it's a fairly substantial process, but, you know, once you've got that item number, it is really, really worth it for a new technology, because basically our medical benefit schedule is not budget constrained. Well, it is budget constrained, but it doesn't have a cap. So, if your new technology takes off and everyone's using it, they don't say, oh, we've done enough now, you have to stop, because it is an uncapped budget. So even though it takes a while, it is well worth going through this process. So some things to think about. Look, this is a really resource and time-intensive process. So as I stated in the beginning, just make sure you're confident of your clinical evidence and don't rush in too soon. It's just not worth it, and you want to avoid having a rejection and having to go in with new evidence and going through the process again. So clinical evidence before you start using all this time and resources. Secondly, as a consulting firm, of course, I'd say this, that it is really important that you get good advice. And I would always recommend that companies who aren't absolutely sure of their clinical evidence do a feasibility study first. So this is, just an examination of your evidence from an expert's point of view who's used to doing MSAC applications to say whether they think you've got a good case or not. Because it's better to get that little bit, do that little project up front and get that advice and know what you're doing before launching into the whole process. So I would always suggest that as the first step. Also, be prepared for delays. Sometimes, MSAC might come back or the S might come back and ask you to remodel something, particularly they might say, oh, we don't like the way you did this bit in your economic evaluation, or, we'd like you to change this, or we really want to have a look at this population a bit more closely. So that can cause a delay. But, and you can't really overcome that. All you can try and do is do your main submission as well as you possibly can. But health economics is a field where everyone has an opinion and there's always an alternative way of doing something. So, this can happen. And I'd always advise all of you to go and have a look at the MSAC website. It lists every single application. The most recent applications, they'll have a lot of the documentation up there, like the initial application form, so you can go have a look at what other companies have submitted and see the sort of things that have been done. Mostly they won't have the main submission up on the website, but sometimes they do. But you can really get a lot of information just from looking at the initial applications, and it'll give you an idea of how these things are normally done. So that's pretty much it. So has anyone got any questions? And I will wait to hear from Louise.
Hello, Sarah. Thank you for that presentation. Most valuable and very detailed. So at this point, we'd like to remind our participants to submit your questions via the chat or the Q&A button in the bottom middle section of the Zoom webinar. We've had a few questions come through, Sarah. Some of them perhaps focusing on the comparisons between the US as a large market and Australia. Is there something you could comment in regards to the differences or similarities between the US process and this Australian MSAC process that you just described?
Well, I think the thing with, the US, and I don't pretend to be an expert on the US, is that once we essentially have a centralised system. So once you get that MBS item number, everyone's pretty much obliged to pay for it. Obviously, and it forms the basis of our DRG system as well. So you really only need that one item number. So it's very comprehensive. So you don't, that once it's in there, we don't have the same range of codes like the CPT codes and the CMS codes and the variety of codes that you have in the US. We really just have that one code. So it's a very comprehensive, you know, once you've got that, and depending on your technology, it does mean that the doctor or the other type of health practitioner who uses it will be covered for using that device. So I see that as the main difference. I mean, the market obviously is very different because we're 25 million people and the US is, I don't know, how many people have you got there, Lewis? 300 million?
Around so.
Yeah. So that was, I would see that as the main difference, that it's just this one step.
Great. There was another question. How do you make the determination whether going through a lengthy MSAC process is required for a new technology? And if it's not, what does the process look like?
Well, it all depends on the technology. So if there's an existing item number, you know, an MBS item number for your procedure, that's great. You know, you need to determine that first. So, and you can, MSAC doesn't take kindly, and our Medicare system doesn't take kindly the people who are using really new technology that really hasn't been assessed by MSAC. So a really good example of this is when transcatheter valves came to Australia. So we had a Medicare item number saying implantation of aortic valve, which is pretty straightforward. And so a lot of doctors started using the transcatheter valves, which were, you know, obviously a revolutionary new technology, and very quickly Medicare changed that item number to exclude transcatheter valves because transcatheter valves had not been assessed by MSAC. So even if you think you've got an item number that covers it, if it's a really, really new technology, you probably still have to go through the MSAC process. But the best thing I can say to people is just get a feasibility study before, you know, when you're entering the market, and just know what, you know, what you need to do, because there's all sorts of coverage for devices in private hospitals through the prosthesis list and other things, and you need to be aware of this, because we must remember that the medical benefits schedule is a list of physician fees. So it means that people get paid for using your device. So there's a lot of answers to that question, and I would really say you need to get some good advice depending on what sort of medical technology you have.
Thank you, Sarah. I had another question here. The CER part of Australian regulatory approval process sometimes allows approval without direct clinical evidence. Could you correlate that to your statements in regard to MSAC requiring clinical evidence directly?
Okay. Yes. Look, this is people often get this confused, but it's two completely different things. Having, you know, getting through the TGA and using a CER, all the TGA is saying is that you're allowed to sell this device in Australia. You know, we have assessed that the risks of selling this device are acceptable. But that doesn't mean that the Australian government is obliged to pay for it. So that's a quite different decision, and it's completely separate to the TGA. So people often think, oh, I've got a clinical expert report and it says my device is just like a lot of other devices. And that's true. It's fine for registration, but it's not enough for reimbursement necessarily, depending on what your device is. So the next decision is this technology good value? Is it worth the taxpayer, you know, is it worth the taxpayer's money to pay for it? And that's a decision of government, and it's based on the clinical effectiveness and the cost effectiveness. It's completely different. So while a CER is useful for registration, and you know, if you've got a Me Too device, you know, you may be able to start selling straight away. It's quite a different assessment. It measures different things, and it is not. You can't be used for an MSAC.
Sorry, just to follow on that. So does that mean that a product without a direct clinical trial cannot go through the MSAC process?
Pretty much. It depends, but you've got to remember that if there's an existing MBS item number that your device is covered for, like say for example, you've got a new type of hip replacement. Hip replacement is, on the medical benefits schedule, doctors get paid for it, unless it's, some radically different way of doing the procedure, like the example I gave you with the heart valve. Then you don't have to go through MSAC. It's only the new procedures. So it's not everyone that needs to go through an MSAC.
Thanks for that clarification that only new and radical procedures really have to go through this lengthy process. We have time for a couple of more questions. If you have any, please send them our way through the portal or even the chat room. I have a question here, Sarah. You mentioned that you need local, I'm paraphrasing here, local physician support or industry support. How is that support secured, and are basically key opinion leaders comfortable and well knowledgeable in regards to providing this level of support?
Yes. So this is quite something. This is things that the Australian colleges of the various medical specialties will be very, very used to. So, but if you haven't, if no one knows about your new procedure, I mean, obviously, it's going to be hard to get support. So part of your job is bringing this technology to Australia, is garnering support. So something I probably should. Something that happens in Australia that's a bit unique. As I said, the medical benefit schedule is a list of procedures that doctors can charge Medicare for. Our public hospitals, most doctors are employed by salary. So quite often you can start doing procedures in the public hospitals without a Medicare item number if the public hospital is keen to do that procedure, because the doctors aren't billing Medicare directly. So that's a little complicated, that's a very complicated little scenario that, if anyone has any questions, I'm happy for them to email me directly and I can go through that in a bit more detail. Probably too lengthy for this webinar.
Great. Well, we're almost getting to a wrap up. There's a chance we could still get any pressing last minute questions. I think we've sorted through the general subjects of most of the questions that have been submitted. If you do have a question, we wanted to sort of share how to get in touch with Brentwood Biomedical. We're global regulatory experts. If we don't have a direct answer for you, we'll make sure we connect you with someone who has the answer for you. So you can contact us through help@brentwoodbiomedical.com. And we wanted to encourage you, if you've enjoyed this, to make sure you potentially mention it in social media or sign up to our multiple channels to stay connected with us. If you're interested in staying abreast of the upcoming changes, we do cover a wide array of subjects, going from Australian reimbursement, which is very specific, to harmonization efforts that expand to the entire world. So please follow us. We are presenting here the information on how you can find us. I don't think I have any new questions. It might be sort of a record time here that we might be ending it early. Sarah, did you have any additional comments or thoughts you'd like to share?
Look, I just think it's always, what I'd always say to people who are thinking of entering the Australian market, it's a really good market to be in, and it's it's a really sophisticated, well-resourced healthcare system. It's probably one of the best in the world, really, but it is a little complex, and so I just always think it's worthwhile just people just getting a feasibility study, just knowing where they stand before they sort of launch in. Having a bit of knowledge makes such a big difference. So that's the only thing I'd suggest.
Okay, wonderful. Well, this has been another webinar provided to you by Brownwood Biomedical. Thank you all for signing up. We had people from multiple continents, and I know sometimes schedules are not the most convenient. We'll be making this available to you, even for those who signed up and weren't able to join. You will be receiving an email. Please contact us if there's any questions, if there's any way we can support you. As you've heard, Australia is a very attractive market. Considerations of undergoing an MSAC process are large, but not unsurmountable. We're here to help with that, and we look forward to providing you additional support and additional value-add programs for your consideration. So if you have any suggestions on new topics you'd like us to consider, please send us our way. If that is all, we will be contacting you or seeing you in the next webinar. Thank you very much for your time today, and have a great day.